Good afternoon. We will start in few minutes. Okay. Okay. Good afternoon, everyone. Uh, just let me make sure we are ready to roll on YouTube also. Dr. Atisha, are we ready? I hope you all can hear me. Dr. Atisha, is everything ready? Can we roll? Okay, thank you very much. Okay, so good afternoon again. All of us are here for one more summer. And today we are going to talk about heat-related surveillance. So from this year, we are updating the reporting format, and I will talk about it. Before we start, we also have our head of the division NPCCHH, Dr. Akash Srivastav, and I would like him to start the session with his opening remarks. Sir, over to you.
Thank you, Dr. Purvi. I just wanted to confirm with NIDM that when Dr. Purvi was speaking, was the voice clear from what we were hearing? Because I felt some disturbance, so I want to know if others could have heard it clearly. Can anyone from NIDM confirm who is moderating the session? Voice was clear. Okay. Right. So you could be heard fine. That's good. Okay. So good afternoon, everyone, and I don't know. Some people are saying they can't hear, and some are able to hear. So I'm not very sure of what's the issue. But anyway, good afternoon. You all know that we would usually start our surveillance on the 1st of March for the given summer. And one major important change that is happening is that all states will shift to case-based, or what we call patient-based reporting this summers for each surveillance. And therefore, while the pilot was done in 7 states in the last summers, as all the remaining states are going to move to patient-based, or what we call case-based reporting, this purpose of this meeting is to train you people and to resolve your queries, if you have any, after initially taking you through the portal and the components that are inside it. And kindly take a very careful note, because over the years we have been successful in increased participation of healthcare facilities. And the target we set now is that almost all health facilities to ensure their participation throughout the summer months. Irrespective of whether the cases are there or they are not there, reporting is compulsory or mandatory, and all efforts should be made to see that whatever you report in the correct form, so that it's meaningful to use the data that is generated from your reporting unit in context to understand the challenges that your district faces in regards to heat impact on the population of your district. So my purpose of the opening address was to only touch upon the importance and the relevance of you all attending this training with careful understanding. I will also request Dr. Purvi to give them opportunity to play around with the portal a couple of days prior to the actual reporting starts, so that you can experiment if there is a provision for the same, and have your proper hands-on clean to start clean slate on 1st of March. With that, thank you for being here with us. We have quite a large number of healthcare facilities joining across the country. So Dr. Purvi, can you please take over from here? But again, have a check if there is a clarity in your sound reporting system.
Yes, thank you, sir. Okay, so is my voice clear? Any issue people are not able to hear? I can try changing some things.
I don't know. I for here find it very distant and slightly toned down for some reasons. I don't know if we've checked case with my headphone. That's why I'm
Yes.
asking, be sure that the others are not facing
I
this.
think some people are reporting it better and others not.
Yes.
So, okay, sir. Uh, I'll try to speak louder and near the mic, so I'll try to be better. Okay, so before we move on, some things, I think some people are on YouTube and it's taking time to start it there. Don't worry, this session is also recorded. So if some glitches is there on the other side, we will be able to share the recording link. But the people who are here, let's begin. I'll share my screen and start with the presentation, and then I will show you online on the portal how it goes. So, okay. So from this year, we'll begin case-based reporting. And just to give you an overview, last year was the first year where global temperature went above 1.5 degrees Celsius. Yeah, so this is the first year where we breached 1.5 degrees Celsius, which was our target to not reach under Paris Agreement. And that makes sure that all the years we are going to experience will be hotter. If we talk about number of days that we experience extreme heat, if you see on the rightmost side, 2024, it shows that almost all days of the year had higher temperature. The light brown ones are more than 1.25 degree temperature exposure, and the dark brown one is more than 1.5 degrees Celsius temperature exposure globally. So in whole year, we have experienced unusual heat throughout. Last year, together, the country reported for 48,001 suspected heat stroke cases, and suspected heat stroke deaths were 268, and confirmed cardiovascular deaths were 2,000, and confirmed heat stroke were 159. So this is a cumulative reporting of the whole country between March 1st to July 31st. And it shows the impact, like in terms of heat stroke cases, 48,000 is a big number for a country. So and this was a reporting from around 50% of the health facilities in the system. So we can understand that it is underestimate in many ways. And for coming year, January 25 was already a hotter month based on the previous reports. So we are already experiencing high heat for any January that were experienced before. And although this year is a La Nina year, and usually for India, La Nina years bring more colder temperatures, not very high temperatures, and better monsoon. But because the January was hot, even though we are having La Nina, the temperature have shot up. So if you see on the rightmost blue dot, although it's supposed to be colder, you see the height of that blue dot is much higher than the previous bar. That means the temperature have increased, although it's supposed to be colder than previous year, which was an El Nino and hotter year. So we are expecting it to be hotter. So considering that, we have more evidence of high heat stress. And if you see the left hand side map, you can see that India has experienced strong heat stress for around 250 to 260 days. So it is a long time of strong heat stress. And this was a report from Lancet, and it shows again India in a very dark color. Darker colors more shows a higher probability of heat-related mortality among people who are 65 and above, if the temperature and greenhouse gas emission remains 2 degrees. So this is the impact of heat on health. I think lots of people are not able to hear, and I'm not sure. Let me change my mic setting. Maybe a little better now. Okay, so we come into surveillance. What is the purpose of surveillance? So because we are collecting daily data, we are assuming that with this data collection, we can assess the burden of illness and mortality due to heat in the population in near real time. So whatever you report today, it reflects the actual impact that is happening today in day-to-day basis. In that terms, it is very important for response purposes. If the death and mortality are morbidity are increasing, then we need to prepare more. And respond accordingly. Is my slide visible? Dr. Brita, can you see? Okay. Our second purpose, so that is a near real time. In the short to long term, if we have the important the information of morbidity and mortality, we can actually use it as a vulnerability assessment in our action planning at state, district, and national level. So it is a very useful indicator of vulnerability if we have good amount of data. And in the long term, we will be able to understand whether the impact of climate change and our adaptation is making any difference in people's morbidity and mortality. So it is the purpose of heat preparedness surveillance. And this is the action plan that we have. I'm sure now most of you are familiar with the action plan. It has different impacts: medical management, preparedness, and surveillance, drug investigation form. So these are some of the things that are of action plan, and we are using it every year to prepare for preparedness and surveillance programs. Now coming to indicators. What indicators we are collecting in surveillance? So for better understanding, left side is a direct health impact of heat. In that case, we are collecting suspected heat stroke case, suspected heat stroke death, and confirmed heat stroke death. Right side are indirect impact indicators, in which we are collecting emergency attendance, whether it is OPD or IPD, is based on your facilities service provision. It can be medical, pediatric, and casualty, whichever is there in your health facility. So this part is common for the previous year's surveillance data collection. Similar to death reporting, we are collecting confirmed cardiovascular death, suspected heat stroke death, and other deaths. So these are the indicators, and how we are collecting it, I will show you now. So before we move on, it is important to understand the concept, how the data is going to flow, and it reflects on the dashboard in terms of numbers. So first of all, we are assuming that suspected heat stroke gets admitted in the hospital, and it gets maybe treated and recovers or referred, and sometimes a patient may die. If it's a death, it is a suspected heat stroke death. Sometimes the death, people come as a broad dead situation. In that case, they are added to suspected heat stroke death category. If you are able to properly, assess the facility whether they are heat related or not, and then from there you can confirm a heat stroke death. So these three indicators are flowing from each other, and they are actually proportion of each other. So that is how it is reported. It will reflect on your dashboard. Just to show it pictorially, if there is a health facility, if a suspected heat stroke cases represent a green bubble, heat stroke death will be a smaller chunk of it, and then confirmation of heat stroke death will be even smaller part of it. So the largest number of indicator will be suspected heat stroke case. Death will be part of it, and confirmed death will be again part of suspected death. Usually, that is what we are expecting. However, in case of broad death condition, people are directly will be added to suspected heat stroke death category. These are the case definitions, and they are for action plan. So you can also refer from action plan, and I will also share this presentation. And there are modules. So this information is available in the guidelines. So what is a suspected heat stroke case? It has three characteristics: altered mental status, elevated core body temperature, or hot and dry skin without sign of stroke, history of infection, and sign of medical overdose. So this is, I think, more familiar with all of you now that you will be submitting data. We are not expecting confirmation of the heat stroke case by lab diagnosis. That is not required. We are accepting suspected heat stroke case because that gives us more faster information rather than waiting for lab testing and exclusion of the illnesses. And then suspected heat stroke death is a death of the case, suspected case, or broad dead. In case of broad dead, there is a checklist criteria that I will show you, which can help assess and label the heat stroke death. Third is confirmed heat stroke death. It's based on clinical confirmation. Confirmed heat stroke death can be confirmed by the treating physician clinically. It can be post-mortem, it can be batch investigation, that is a verbal autopsy, or any kind of audit mechanism. That is fine. We accept clinical confirmation because we expect that clinicians are better judge of identification based on whatever clinical information they have. So post-mortem is not mandatory for confirmation of heat stroke death in the health facility setting. And cardiovascular deaths are easy. It's MI, HS, cardiovascular procedures, or other cardiovascular hemorrhage or other cause. This is the criteria that I was mentioning. How to label heat stroke or heat-related death in a clinical setting. This will be circulated again. We have shared this last year. And in the scenario where it is not possible to measure body temperature, this can be used. We have identified different markers and indicators that can help physician, clinician to just label a heat stroke death when it comes to reporting. So if the assessment is not available, temperature not measured, or no other information is available, how would you label heat stroke death? For example, here in the last row, patient is drawn dead. Then you consider the environmental criteria and the other physiological vulnerabilities, and then you can label the patient as a heat stroke death for the purpose of surveillance. So this part is useful for that. Yeah, these guidelines or autopsy findings that can also be helpful when the autopsy is considered. And this form is a verbal autopsy form where circumstantial evidence can be collected and then can be determined if a death was heat stroke, confirmed death, or not. When the other clinical information is not available, this form can be used to help determine the exposure and other things and identify or label a heat stroke death. So these are the tools and resources, and we will share this again. Now I will go to data collection portal and it's okay because many people are telling me I don't know. Is my voice okay? Some people are no. Three sections. Is case summary, emergency medicine, emergency pediatrics. Okay,
Dr. Purvi, we can't hear you.
I'm trying to put my Bluetooth if it is better or better mic in that. Am I audible better now?
Yes, you're audible, Abhi to.
Okay,
It's clear.
so I was trying to check that. Yes.
Okay.
Okay. So this is the form, and this is the first section where the aggregate data collection happens, and it is almost similar at the last 2 years form. So we'll go one by one. In the first, okay, so there are some changes that we have mentioned here. Start from login page. Okay, I'll just go back to login page quickly. So this is the learning portal, remember, okay? This is not a live portal. So if I go to ihiplearning.in, this is the first page. On the right side, I go to NPCCHH. I will enter the credential and sign in. And I will share everything with you for practice on this portal. And I go to form. This is how it starts. It has NPCCH logo, so you know that. On the top section, there are links, and I will come back to those links afterwards. If you see here, you can just see daily enter new patient record for all heat stroke cases, deaths, and cardiovascular deaths. That is where the form has changed, and this will be the patient level data that we will be entering for heat stroke cases, deaths, and cardiovascular deaths. Okay. So if I move forward, reporting date will be by default the day that you are reporting, that is today's date, today. Now we go to case summary. We have 3 fields here that are empty to be filled: emergency medicine, emergency pediatrics, and casualty. Whichever division you have in your facility, you need to select that and enter data in that field for that particular unit that you have selected to reflect here consistently throughout the year. So we have put an instruction here to identify applicable department in your facility and report in the same category daily. Do not double count the same patient. Okay. So this is the measure that helps us understand how many patients are coming daily and whether the temperature is changing the pattern of emergency admission. So if your facility is very small, if you only have casualty, you can put emergency medicine and pediatrics as 0, and you can put numbers in casualty 1. If you only have pediatric emergency, you can just put number in that every day, and you do put 0 for others. So let's imagine we have a big hospital, we have emergency medicine division, and it is inpatient. So we will put that number. If your facility only has OPD and all the emergency goes through OPD, you can put OPD number. So that is why we have kept it little bit non-specific, because each health facility has different kind of service provision units. So you have to decide which one represents your emergency medicine better. Idea is that unit should be able to cater a heat stroke patient. मतलब a heat stroke patient उधर से आपकी फैसिलिटी में एंटर होना चाहिए. So that is what gives us a denominator here. और उसमें से one of that is heat stroke. Imagine there is a pediatric facility. So we had 18 pediatric emergencies. There is no casualty division. I'll keep it as 0 here. So that is for that. Now, when I'm putting these 3 numbers in this field, it will automatically make a total of total emergency here. Okay, so this is a auto added field. You don't need to put anything. So this section is now done. The top section is completed. Now we come to deaths. In the deaths, the gray zones are not open to fill up. Only white zone is open to fill up, and that is the total deaths in the facility. Here you can put all the deaths in the facility regardless no need to remove anything. You can put whatever is the total number of deaths in the facility. Okay, so all the white fields are open to fill up, gray fields are not open to fill up. One point I wanted to make here is in the case summary, when you put emergencies, we try to not take a particular division which only caters to accidents. But if there are accident people coming within your emergency or pediatrics, it is fine. But we do not want only emergency of orthopedics. So we will not think about having those accidents or orthopedics or other emergencies here. This is more of a medicine and pediatric casualty and emergency. Once you put the data here in this field, save case summary is required to save the data. So don't forget. Sometimes people forget, and sometimes data does not transmit if they forget to press save case summary. So make sure they press that. Now comes to the other fields that were not open to fill up. That will be filled up from a new patient record. This field, so you will have to click on that. And this form almost looks like the section 1, the blue one is a patient detail, which looks like IDSB data collection form. It is not very different from there, except few questions. So I will just search a dummy patient and try to put and show. Let's select a patient here for training. Almost all information are there, which are mandatory. 3 questions, 1.23, 1.24 are different for our surveillance, which are added here. So 1.23 asks about socio-economic card with BPL, Antyodaya, Annapurna, other none. Whatever is applicable, select there. It's a compulsory field. Last occupation. This is a question that asks about different occupations specific to vulnerable population. And it is divided into major categories, occupational categories. So, by reading it is easy to identify: construction worker, laborer, cycle rickshaw puller, outdoor cleaning sanitation workers, vendors, postmen, delivery persons or gig workers, emergency responders, firefighters, health professionals, then guards, traffic policemen, professionals or trainee athletes, farmers, homeless, factory, homemakers, students, unemployed, and others. So most of the vulnerable population will be coming in categories. If they are not, there is an option to put others, and it can be put here. So this category requires a little bit of attention on selection and writing of it. 1.25, we asked about exposure. So we have tried to categorize it, although it's very difficult, but for sake of data collection, it needs to be categorized for better understanding. And if you see here, is outdoor, and the patient was sitting, traveling in closed vehicle or other non-exertional activity. Next is outdoors, whether working, exerting or playing. So that is a combination of exertion and outdoor heat. Then third is near the heat source, where the additional heat is gained. Is it a fire, furnace, hot engine, or machine? This is the indoor exposure at work, school, office, or home. And the last one is mass gathering, special events, or rally, or tourist places. These are some of the options for categorization of the patient exposure. So this needs to be properly collected when there is an interaction with patient and categorized accordingly. These are the three specific questions. in the first section. Now we are coming to second section. In second section, now we are asking about diagnosis. And if you remember, I already showed you that we are only accepting these two cases death and cardiovascular death. So if you come here, only two options are available. Let's go with suspected heat stroke. This is a case. So if you select this, it is a case. Then you enter date of symptom onset. Assume it is yesterday. So we enter yesterday's symptom onset. Then patient probably came in IPD. And date and time of admission. Okay. Today's admission, yesterday's exposure. When patient is, I'm reporting today, when patient is still admitted, so I will select admitted. Here it is admitted. Patient improved after cooling? No. So that is that option. Does it have, he have any chronic medical condition? So you can select whichever is applicable here. Hypertension, yes. That's it, only one condition. If you can select here any other, it is fine. It's a multiple option. If you don't know, it just select don't know and other things will disappear. So let's select hypertension. And so that is it for reporting and admitted suspected heat stroke case. Make sure it is saved here. Only if you save, it will be saved in the line. So everything is picked up. Whenever it saves, it will turn green. Data saved successfully. So if it doesn't appear, this means something is missing and it needs to be. So now we have a patient entered here in the line list, and it's so this is the patient we entered, and it shows as admitted, and it shows as a red because final status is yet not known. As of now, patient is admitted. Okay. So I'll just go up and show you other scenarios. So if patient has heat stroke, and if you select refer or recover, you can directly finish the form with a similar kind of option. Okay, there is no more options to be filled up. But in case patient died, so if you enter patient here died, then it will ask for more information, and it will look. The third section will appear. Whenever the death is reported, few more things need to be answered. So whether the death is confirmed or not, so you report no, it is not confirmed right now. Was the patient found dead, unconscious? No, because this patient came from hospital, so it is no. And time of death. So if death has appeared, you have to select the time and the time of date of death. So this is a simply straightforward. And then for confirmation. So if you have confirmed that, then you fill up this. If you not, then you can just complete this right now and come back again when it is confirmed and upload this document. Okay, so this is one addition modification is there for died patient. Now there is another option because we are still not finished with the trajectory of heat stroke impact. This is the person we just entered a few minutes ago. This one. Okay, it is admitted. Now, if his status changes after a few hours or one day, you can come back and edit this person and it will appear down below. So now we are coming to report that person is probably recovered. So you can change the final outcome at 2.10. When you come to edit, this section will open. Final outcome. And then you can select deferred or recovered. And then date of outcome. As recover, if they recover why, so you can say date or whatever it is, and then update. So this record is then updated, data saved successfully. Now you can see this patient here, this one, which was this one, has recovered. So this is like complete line of data collection is over for that. Now assume this person died, the same patient I am showing you here. You can come back here, change it to died, update the information of death. Let's see, you know it is confirmed death. You add the date, time, and then it will ask you to select on what basis the confirmation has happened. So confirmation of heat stroke is based on any of the whatever is there done. Clinical case. Okay, so you select that and you update, and you can also select to update the upload the form. Here you need to update, like, so it will open and allow you to upload the case sheet in the image format or PDF format, and this will provide more information about it. So we have allowed to enter upload a document so that we don't have to fill up a lot of information in the form. So that is the idea. So kindly upload the document. It will allow you to do this up to 15 days after the date of death. So there is a provision that will stay open to upload. This was all about heat stroke, and as you fill up the information, it will aggregate here on the top based on one death or whatever that criteria is. It will be showing up on the dash in the gray field. So that will automatically count. Now, last thing I will show you here is, let's assume there is a cardiovascular death. You just select it and you just fill up this information. There is no more information is required for cardiovascular death other than OPD, emergency visit, if you know any chronic condition, and if disease count, the person was found unconscious at death, just at workplace. So this information is required if a patient is found unconscious or dead, and then you can just finish this format. So this is largely format of data collection. I'm just trying to fill up this information so it can save. Otherwise, it will not save the form. If something is missing. All of this missing. Anyway, so this is just I'm showing for cardiovascular. Okay, so that is over for the form. In the line list, you can see all the information here, whether patient, what is the status, and final outcome. In case it is admitted and the final outcome is not yet done, it will show as a red. So you can come back and edit it later. So that will be visible indicator that this patient is yet admitted and his data is not finalized in terms of final outcome. So that is the provision there. Yes, just on the top, there is a case definition. So it is on the, will take you to the bottom part where we have kept all the case definitions, what to fill up there. And then these are heat wave warnings at district level. Right now it is not, there is no heat wave warning, but it will open to IMD's heat wave, district-wise heat wave warning map. For anybody who is interested to knowing what are the warnings in the area currently, they can open and see it. This will open the checklist to label heat-related death, and it is you have to download it. It's on a document like this, and you have to for you. Same, there are some questions. If anyone interested in knowing more about it, they can download. So this is a form. If you have any questions, kindly write. I will address it from the chat box. Okay. I will go back to presentation now. I will. I'm trying to open the dashboard also so you can see. People who are raising hand, I will come back to you. Okay. Are you able to see the dashboard I'm trying to open here? This is how it looks like at state and district level. Okay. This is the dashboard, and the data that is filled up is visible here, and each state can see the district, and district can track their own data collected here. It's taking some time to load, but this is how it looks at the state and district level. So kindly, states and district nodal officer, please monitor. It is very difficult to modify the data later on. So kindly be vigilant about data collection and monitor regularly. Okay. So there are some questions about emergency medicine. Let me come back here. So, purpose to collect this information in the field here is to have a denominator or understanding of how total admissions or medical admissions change with the temperature. Because most of the impact of heat is on NCDs, non-communicable disease, mainly cardiovascular disease, respiratory disease, kidney diseases, and having a medicine and pediatric emergencies allows us to understand what is exacerbating, how much more patients are coming compared to every day. Suppose from last month average patients are coming around 250, suddenly there is a heat wave and we are experiencing more like 700 people getting admitted in medicine and pediatrics. That gives us some understanding, and if we put statistics to it, we can actually have some sort of estimate of heat may be leading to this many exacerbation of patients. So that is the reason we have emergency medicine and emergency pediatrics and casualty, and not emergency orthopedics or surgery, because the impact of heat is more on NCD like diseases that usually come through emergency medicine and emergency pediatrics for children. So is that clear? Is there anything else I can add to that? I can't see people. Atisha, can you help me with questions if you're there? Or Dr. Tanu, I'm not sure if she is there. Same with the total deaths. So increase in morbidity and mortality both is important with temperature. That is why we are also collecting total deaths. It's like all-cause mortality that we hear in the literature. That's what we are trying to capture here. Okay. Dr. Manzoor Ahmed, okay, can you just quickly ask a question? I tried to unmute you. And okay, civil surgeon office, Patiala.
Yes, I want to ask about this. In last year, we have some random entry done by one of
Yes,
blocks.
yes.
तो उस केस में हमें मतलब ये ट्रैक करना पॉसिबल नहीं हो पा रहा था कि किसने एंट्री की है ये वाली। हम अपने ब्लॉक्स में फर्दर डाटा नहीं देख पा रहे थे।
अच्छा, मैं आपको दिखाती हूँ where it might be visible at your end. Just let me go back to this. So to see for facility level data.
ये फिल्टर्स लगाए थे हमने ULB
नहीं,
हाँ
yeah, I will show you. So if you have to go to aggregate report, so that is like a fourth tab from the top here. Okay, and then we select state-wise. Maybe it is visible district-wise at your end. My end it is state-wise. So let me select some dates. Search. Okay, and then I select a state, suppose it's Goa. Then you see here facility-wise report. So
Okay.
you can export facility-wise report here. So that will give you very comprehensive daily report from all the facilities. So if I download and show you, you can
Okay,
see
fine.
date-wise data. Okay. Yeah.
ठीक है, thank you.
Yeah.
एक चीज और
Yes. Sorry, I lost. I think you need to unmute again. Yes, sir,
मतलब
बताइए.
एक चीज और कहना चाहते हैं कि इन जनरल मतलब ये हर एक प्रोग्राम ही कह रहा है कि डिजिटलाइजेशन चाहिए, हमें हर एक के कंट्री चाहिए, लेकिन करने वाले लोग तो हॉस्पिटल में उतने ही हैं। तो ये दिक्कत आ रही है कि मतलब अभी एनसीडी का भी डाटा है, हर चीज का डाटा है, तो मतलब मेडिकल कॉलेज हॉस्पिटल्स हैं वो स्टाफ की डिमांड करते हैं इसमें, मतलब असिस्टेंस
Yes,
चाहिए
sir.
हमें।
वो तो मेरे हाथ में नहीं है. I hear it, but I can. It's not something I can. I mean, I wish I could, but I can't. So
नहीं,
we
उसका
hear a
solution तो
lot
हमारे
of
पास में
requests.
है।
Yeah. Yes, sir. Okay, sir. Thanks. Okay. Let me go back to presentation. There are some points. Any more questions? Maybe. I'm sending unmute request to few people who have raised hand and they can ask questions. Dr. Megha, Satyendra Singh Yadav ji, and yes.
Hello.
Dr. Megha.
Yes, a very, very good afternoon, ma'am. Thank you for
Yes.
keeping us update about everything. Thank you so much.
Okay.
Hello. Am I audible,
Yes,
ma'am?
I hear it. Yes, yes.
Okay, ma'am. I had this query last year also. The portal was showing the cases of heat stroke as well as heat trip, but there were certain cases of heat exhaustion which were neither to be reported in heat stroke or not heat death. What was
Yes.
to be done about those cases?
So, madam, usme the reason is so we many years ago we used to collect all heat related illnesses, and we realized that there is a lot of confusion about how to identify those illnesses. We used to get a lot of weird syndromes which are not actually categorized as a heat wave. So we just limited it to heat stroke because it is the most fatal form of disease, and I think capturing it gives us a more solid idea about severity of impact. Although I understand heat exhaustion is important, but
Because all the
identification.
cases, yes, ma'am, yes, of course, because all the cases reaching to us are not necessarily categorized under heat stroke. Some
Yes.
of them are mild cases also, but they do have to be reported. So in those situations, we are missing out on the cases of heat exhaustion for sure.
Yes, ma'am, that is yeah, we understand that. But as you heard about the previous speaker, reporting of data is always a very fine balance among how much you want to
Yes,
collect and how much you can actually report. So we are
of
limiting it to
course.
most severe form so that it's not
Okay.
burdening the system. Yeah, but
Of
we
course,
understand
okay.
we are missing on this. Yeah.
Okay, ma'am. Then in those cases, we are here to notify about more severe cases. It is now
Yeah.
it is clear to us that we can skip on certain mild cases, and what we have to prioritize is to report more severe cases.
Yes, in terms of reporting, but you as a doctor, you always should understand that how much people are coming as a heat exhaustion, so that at least you are prepared for that. We don't, we
Yes.
don't understand or know it, but you as a hospital, administrator should have that understanding
Of
at your
course,
end.
of course.
Yeah.
And if I may ask for another question, if the time
Yes.
permits, can I ask?
Yes.
Thank you so much. I had this problem during winters. Though it is not related to summers, as such, I've not reported such cases. Many of the cardiovascular cases or many of the stroke cases were indirectly related to cold. So, how come these cases are we supposed to report them? Because cold or any weather change is an indirect cause to that.
Yes,
So, I wanted to ask that.
we are not directly reporting cold impact, but we are actually, this portal is year around. And although we say heat related, we if we collect data and people report daily data on emergencies and total deaths, we can have some understanding of what cold is doing to people and their admissions
Yes,
and
because
mortality.
as an observation for in last 3 months, I've observed, we have rather all of us have observed that number of stroke cases and MI cases have certainly increased during winters,
Yeah.
and that too in age group 45 to 55, which we see in
Okay.
our hospital. That is, we are catering to the urban population
Right.
of Jammu district. So what we
Okay.
are seeing is deaths of MI cases between 45 to 55 more in
Yeah.
winters. So, but cold is an indirect cost to that. But
Yeah.
certainly it plays a role in that now.
So
So
we
I
we are
want
we are capturing cardiovascular death. So if it is reported consistently, we will have some idea of cold's impact if we analyze it properly.
okay, so that way we
Yeah.
have to go for heat related case reporting also.
Sorry.
Meaning on the similar lines that we have to go for heat reporting cases also, heat being an indirect cause for things.
Yeah, so when you report cardiovascular and emergency admissions and total death, all those these indicator will help us understand indirect impact.
Okay,
And
ma'am.
heat
Thank
stroke
you.
is direct impact. Yeah.
Okay, ma'am. Thank you so much for giving me opportunity to share my doubts.
Okay, thank
Okay,
you.
ma'am. Okay.
Okay, shall we move on, because I think we might lose some time. Let me get back to my presentation. Are you able to see? Now I don't know what is that. Is my presentation visible?
The presentation is not visible. We can still see the portal on your side.
Okay. This juggling thing is so difficult. Okay, now let me share. Okay, I will quickly go through because I already shared, and this PPT will help you share this information or teach other people. So yes, the portal that collects data is mentioned here, and I hope you all know it's ihipmohfw.gov NPCCHH, where health facilities will report with P form level data entry, username and ID. And so PHC and above all facilities are required to report daily. If they are reporting today, they will be reporting from yesterday's 8 a.m. to today's 8 a.m. Reporting is year around. So his stroke cases, whenever they are not there, it will be just 0 or not reported through a patient level, but other cardiovascular and other totals are required to be reported. It's mandatory daily reporting, and 0 reporting is required. Otherwise, it will show as not reported. This is just a form that I already showed you. It's in the single page. These are the sections. I discussed emergency aggregate on the first section and patient level on second and third section. This I also covered. Okay. So I'm just moving because I already talk about it. So remember that you have provision to come back and edit the report. So if the 2.5 status, yes, I will share the presentation. 2.5 you have reported admitted, then there is a chance that you need to report back and edit the final outcomes from admitted to recovered, referred or died. Otherwise patient will show up as admitted all the time and we will not know the outcome. So make sure that it is done when patient status changes. Usually within 5 days we are expected that it will change and you will report update the report by editing it. Yeah. Here when you talk about that, sorry.
Yeah, I'm Amit from NPCCHH-UP team. So I just had one small query regarding suspected heat stroke deaths. So like what we understood from the last year of and surveillance of this heat-related illness and death surveillance. So I just wanted to know that when we report suspected heat stroke death, by all means, it should be get verified and it should convert into a confirmed heat stroke death, or it should be dropped, right?
No. So we do not expect that all the suspected heat stroke deaths will be confirmed. Many times it's not possible to confirm, or it does not get confirmed. It's not. We don't expect it to be all the time on the time. Hello.
We have this provision of reporting even a suspected heat stroke death, irrespective of we don't have any sort of clinical diagnosis to
Yes,
confirm it.
that
Right?
is why. Yes, that is why it is suspected. So clinically, you are not able to confirm right now. You report as suspected. That is why we emphasize on suspected. That
Yeah, because
we are. Yes.
Because the thing is, last year we reported 40 around deaths, which is the highest in the country, and all under the confirmed heat stroke death category. So we also had certain reports with people reporting us that we have some suspected heat stroke cases, but post verification, some were dropped because most of the symptoms were related to cardiovascular deaths. So the only deaths which we have PM certified, or which are certified from the CMO level at the district, we have reported as under the category of confirmed heat stroke deaths.
Yes. So the problem here is, if you guess from this, that it is very difficult to confirm a heat stroke death many times, even through postmortem, because if the exposure of heat is very short, many of the organs do not show the sign of change, the body's organ inside. So it is very difficult to tell something that it is a confirmed death based on organs. And then if we don't count it as a confirmed, then at least we should have suspected heat stroke death count in that count in that, so that at least we have understanding this is probability. Like heat ka impact to hua hai. There is a heat impact, although it is not visible in any other form. We cannot discount that, because ultimately what we are trying to understand is the amount of impact and preparedness. So if we discount that, we will not be able to have a full picture. So we keep it as suspected. We keep that idea open that this might not be confirmed. So that is why the word is still used, like suspected. I think that helps you report openly. Hello. Okay, move on. Yes. So in diet category, broad dead can also be entered directly there in the diet. So this one. Okay, so how it is reflected in the gray field, the counting. So if there is a heat stroke suspected entry, 2.1 is done, 2.5 says admitted, referred, so it will count as suspected heat stroke case. The blue one represents the category of that. If it is died, as at when you report it, or later time, updated status is died, then it will be suspected heat stroke death. And if the confirmation field says yes, then it is confirmed heat stroke death. All of it, this will be subsequential proportion of the first one, the earlier one. So heat stroke death will still be part of cases, and the confirmed death will be still part of suspect death. These are largely a proportion of the previous category. So this is how it will show up. We will not replace or remove a case because it died. This is how the progression of numbers will be when it is reflected. These are just pictures of some of the other categories, and I think that will be. So yes, we accept clinical case sheet as a death reporting confirmation. No PM necessary, no 3-member committee report necessary. As a health sector, we accept clinical confirmation. This is for death. What I have to highlight. Okay, so the live portal will be available from February 26th. It will be updated by that time. And so data collection will reflect on this format from February 26th, and March 1st is the start date. So for 2 days, we can have for troubleshooting and any other issue. So please check that. This is a dashboard, sample dashboard. Okay, this point is important. I think I already mentioned. Once you enter a case, within 5 days, you can update it to another status. And within 15 days of death, you can upload the confirmation. Yeah, try to avoid inform health facilities to make less mistakes. It is very difficult to correct. If there is a mistake, within 5 days, they can correct by themselves. So if they are vigilant and if the monitors are vigilant, 5 days, they can correct the data themselves. More than 5 days, they have to inform us with the proper information and we can correct it. But we cannot correct it right away because it's a very lengthy process. So we will accumulate certain corrections and we'll probably do it on weekly basis. So make sure that you provide us correct information and first of all avoid this kind of issues through monitoring. This is the learning platform and it will also become in the, I will share it on the groups also again, so you can share it with the people who are trying as a trial. This is what we had tried last year, the patient level data entry done by 6 states, and we have received line list of almost 3,000 patients, both that is including the heat stroke and cardiovascular. So these states have tried it and it is doable. So we can all try and effort to do this. These are the training manuals for further training on heat and health, which is available online also. And try to encourage people to report, just like we don't wait to see mosquitoes to report. Please don't wait heat wave to report your heat cases. It should be thorough, done throughout the season, actually throughout the year, so we have better idea. Don't go by your feeling of heat outside. Just encourage people to report throughout the year, whatever is the external temperature, rain or shine. So just make sure they report. Okay, few more things just I will go through because it's we are also emphasizing on preparedness. I hope many of things are available to you for preparedness. We have issued 2 communications. You can see different preparedness in terms of ORS corners and health facility preparedness to provide emergency cooling. So this needs to be prepared from now. Like this is the time you should think about it for planning. So rapid cooling is the the gold standard and the most effective solution for heat stroke and heat exhaustion. If provided in 30 minutes, the chances of survival increases drastically for a person suffering from heat stroke. And this is also I will share. Along with the facility, ambulance preparedness is very important so that they can provide cooling in the field only, in the houses only. They don't need to transport patients to get them cool. They can use different methods, different implements to cool the patient with ice or even water that helps them, reduce the impact on the internal organs and save the patients. There are examples that people have survived just because they were cooled with the water, put in the shade, and active effort were made to cool them. Whether it is a body bag and ice, tarpaulin and ice, or just spray the cold water or put ice packs and repeatedly rub them and try to cool the body down fast. So cool first, transport second requires a lot of efforts. Prepare your ambulances. Also try to have paramedics and emergency responder know about it so they can provide it in the field. These are the guidelines and we will have another webinar on this. So don't worry, if this is too much for you in one go. We will have another training session on this. In terms of preparedness, what you should have is functional basic utilities for cooling and water and some ice storage, proper ice cube, procurement or making, ice cubes, all those things should be there. Somebody is asking about rectal thermometer. It has been difficult to find them. I think last year people have experienced it was difficult to procure through GEM or even Amazon. If I find good source, I will share with you, but it's I'm not sure how right now where to do that. People have tried last year and they were not successful. So the search is on. If anybody of you know, share with others. So health facility preparedness assessment, we will also do this once we are start preparing to assess. And these are the results from last year. So we will try to capture preparedness in different aspects like ORS corners, emergency cooling, clinical management training, other trainings and awareness activities, and try to be better. Encourage all of you to procure active cooling things and train people for that. These are different methods. I think We will see it in the next webinar, another webinar, just to share here. And AC is not the answer. AC is for the people who are healthy and try to have normal body temperature regulation. ACs do not help people suffering from heat stroke. It's not enough cooling, not directed. So make sure that ACs are not the only thing that you have. You should have rapid active cooling methods implemented for saving patients. Okay, I think that's it from my side. Yeah, any more questions? Okay. Dr. Atisha, anything you can see I should address?
I can see 3 raised hands. I've sent them requests for unmute, but I'm not sure if they're. Dr. Manzoor, are you raising hand to ask a question? Dr. Purvi, there are some questions in the chat box. Dr. Prashant Ranjan has asked, can we use dead body bag filled with ice for cooling a person?
Yes, that is the exact thing we have also seen used in other parts of the world. The body bags can be used with the ice and cold water, just to make sure the head is outside, the patient's head is not inside. Yeah, it can be used. It is used in other parts of the world. We have also put that in PIP guidelines, so it can be procured also.
Anybody else who wants to ask the question can either raise their hand or type the question in the chat box.
Is there a way to share PPT here?
In the chat box, there's an option of sharing content just beside
Okay,
chat box. You'll be able to see
Mhm.
content option. From there, just
Okay,
select the file that you want to add. We've also mentioned in the chat box a YouTube link for this meeting today. If you want to get back to it later on, you can kindly access it through the said link. I'm resharing the link again. Sorry. Dr. Purvi, Dr. Deshraj from Lalitpur, UP is asking, is there any separate budget for procuring these cooling material or items?
yes, I think I lost connection.
Yes, there's a question from Dr. Deshraj from UP. Is there any separate budget for procuring these cooling material or items?
Yes, we provided that under equipment in PIP, and if you see PIP guidelines, you'll get more information. And I think it should have been done by now, or I'm not sure how the state has proposed it, but yeah, there was a provision for equipment, like thermometers and multi-para probes and cooling body bag or other things, portable bathtub and other things. Yes.
Dr. Purvi, are you able to share the PPT or do you want me to share the version that you
Just
shared with me?
no, I just wanted to change one slide. I'm just sharing.
Okay.
Yeah. Yes, I'm just putting it here. Any question, kindly read for me. in the chat. So I'm not. So where is that? I don't see the attachment.
Just next to the chat box, there's 3 dots. Under that,
Oh,
there
right.
is content
Content.
option. Yes,
Okay.
yes, yes.
Okay. 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 Mhm. Okay, I put the PPT there in the PDF format. Okay, no more questions then. I'm putting another document. Okay. There is not.
Yes, we can stop. I will request everyone to kindly download the PPT and the other document that Dr. Purvi has shared before closing the meeting so that it is not lost on you. I think we'll give 2 minutes for everybody to download the content and then we can stop the meeting.
Okay.
Everybody will be able to see the file shared from the option right next to their chat box. There's an option called content. From there, you can access the said PPT and the other file.
And thank you, Dr. Atisha, for arranging this from NIDM. It was very timely help that you did.
Thank you so much. Dr. Purvi, I think maybe later we can share the PPT because some people are not able to download it right now.
Yeah.